Good afternoon. Thank you all for joining us. I'm proud to introduce our first speaker today, Dr. Jay Skyler, Professor of Medicine, Pediatrics, and Psychology here at the University of Miami Miller School of Medicine. He's also Deputy Director for Clinical Research and Academic Programs at the Diabetes Research Institute, and among other things is the Chair of the Strategic Advisory Board for the European Union Innovative Medicines Initiative. Dr. Skyler was born and raised in Philadelphia and graduated with his MD from Jefferson Medical College. He completed his internship and residency in internal medicine, as well as his fellowship in endocrinology at Duke University, and he served as professor here at the University of Miami since 1985. He's received dozens of major grants in support of his research endeavors across a diverse field of study, and has published hundreds of scientific articles and book chapters, as well as being a leader in endocrinology and medicine in general for nearly 50 years. It's our pleasure to welcome him to Grand Rounds today to speak about the future of type 1 diabetes management.
Thank you, Dr. Rubin. And I'll go on and just show you the next slide, which is my disclosures. And then we'll move on to talk about the therapeutic goals in type 1 diabetes. First is prevention of immune destruction that leads to the disease in order to preserve beta cell mass or function. Another potential goal is to replace or regenerate beta cells. And thirdly, what has come into the clinic most recently and is really clinically applicable now is automated insulin delivery. And I'm going to talk about all of these. I'm going to start with showing you the data from 60 centers in the United States that go under the rubric of the Type 1 Diabetes Exchange. This involves some 60,000 people. And this is the average, the mean A1C by age. And it shows you that from 2010 to 2012, and then the current, which was 2018 to 19. And what you can see is that in young people, particularly adolescents and young adults, A1C is really horrible on average in the United States. Can it do better? Well, if one is using continuous glucose monitoring, you can see that it does better, that's the blue line, than those who are not using continuous glucose monitoring. And if you use a combination of an insulin pump and continuous glucose monitoring, or even multiple injections in continuous glucose monitoring, you can see you get a much better glucose control than using either multiple injections alone or a pump alone. But one of the other important things that one gets from continuous glucose monitoring is an ambulatory glucose profile. The data are collected and can be looked at, and although a lot of this is too small to look at, I'm going to blow up the important points in the next couple of slides. Here you can see the on the left, the glucose statistics, that for this particular graph, it was taken for 13 days, and the continuous glucose monitor was active 99% of the time. And what one is trying to do is measure the time in range, the time in the target range, which in this graph is 70 to 180 milligrams per deciliter. That actually can be changed depending on the goals that you set for your patient. And here it was 49%, which is really showing that there's 39% are high or very high, and 12% are low or very low, which is really not the kind of glucose level that we'd like to achieve. Here you can see the what a consensus committee said should be the goals for different populations with diabetes. So if you look at typical type 1 and type 2 diabetes on the left-hand side of the slide, you can see it's to get into target range 70% of the time, and to be less than 4% below the range. On the other hand, if you go to the third panel, pregnancy in type 1 diabetes, you can see that the goal there is to make the target range lower. Instead of 70 to 180, it's 63 to 140. And you still want to achieve that 70% of the time, and you want all of the other readings to be less than 140. That's really necessary if you're striving for achieving best pregnancy-related outcomes. In the second panel, you can see actually in older and high-risk individuals with diabetes, you might want to only achieve the target range 50% of the time and have the other 50% be less than 180. So it varies depending on the circumstance, but time in range, a very important metric that we can use. The other information you get, and you can see it in the upper left-hand corner, is the glucose management indicator, which is basically the equivalent of a hemoglobin A1C. In this patient, it's 6.4%, and she's 73% in range, as you can see over there, with an average glucose of 129. The importance about the glucose management indicator is it's better than the A1C because we have high rate glycators, low rate glycators, people with hemoglobinopathies, and all sorts of other reasons why the A1C may be quite variable. But this uses the individual's actual glucose levels to get a glucose management indicator, which is a better overall measure than A1C done in the laboratory. So, if we continue with our therapeutic goals, we can use that tool to help us with automated insulin delivery. And this is a paper from the New England Journal last year, which shows the results with automated insulin delivery in adults. There are 112 who were using the automated delivery and 56 control subjects. And you can see that the percentage of time in range is higher all throughout the duration of the study in the group that's using closed loop. And here you can see by the time of day, it's important that they are really overnight getting into the 80 to 90% time in range because they're not eating and they're avoiding hypoglycemia by having automated insulin delivery and glucose levels, which are measured by continuous glucose monitoring. And this shows you the A1C measured during the course of the study, and it improves with the closed loop system. And most importantly, the percentage of time below 70 in the hypoglycemic range gets better as well. And this system, which was reported in the New England Journal last year, was approved for adults and is on the market. And so we have automated glucose delivery on the market that can control the blood sugar. And just last month, a second paper from the same group looked at this kind of system in children ages 6 to 13 with type 1 diabetes. And again, you can see the improvement in time in range, getting it to be about 70%. And if you look at it during the course of the day, it's really overnight, it's really 80-90% time in range, which is really quite good. Hopefully, it will be approved for this age group shortly as well. So let's move on then to the area which has been my major interest for the last 3 decades, namely prevention of immune destruction to preserve beta cell mass or function. And the immunopathogenesis of type 1 diabetes is schematically illustrated here. Basically, it's an immune-mediated damage to the pancreatic beta cell by T effector cells. Either CD4 or CD8 cells are both responsible for doing some of that. And so what we want to try to do is interrupt that sequence, and there's a number of different places that one can do it. I won't belabor the details of that on this slide, but rather let me point out the sequence of the natural history of the disease as we see it, which is that you're born with your beta cell function intact and the genetic predisposition to the disease. An environmental trigger, perhaps a viral infection, perhaps some sort of food that is taken in, serves to trigger an immune response, which results in the T cell immunity that I mentioned, which causes beta cell injury. And we can reflect it histologically by looking at the pancreas and seeing insulitis, an inflammatory lesion there. And the damage to the beta cells results in the formation of autoantibodies. And they don't mediate the damage, but they reflect the damage. We call them islet cell antibodies, insulin autoantibodies, antibodies to GAD65, to IA2, and to zinc transporter. Those are the ones that those 5 are the ones that are commonly measured, and they indicate that the process has begun. We then can see that you lose first phase insulin response on an intravenous glucose tolerance test, or have dysglycemia on an oral glucose tolerance test. And we call that prediabetes. And then we get to the clinical onset of type 1 diabetes. And the goal of immune intervention is to stop this process and to intervene at any of those points along the way. More recently, we've staged the disease, and we say if you only have the genetic predisposition, that's pre-stage 1, and an intervention there would be primary prevention. In stage 1, you have autoantibodies, and stage 2 also to dysglycemia. And both of those together, it would be secondary prevention if you're intervening. We call that pre-symptomatic type 1 diabetes. And then when you get to actual clinical diabetes, any intervention there would be tertiary prevention to preserve beta cell function. We call that stage 3. And this shows you the number of trials that have been done by the Type 1 Diabetes TrialNet, an NIDDK-sponsored network that I had the privilege of chairing from its inception in its precursor's inception in 1993 until 2015. And these are all the studies that and interventions we attempted during my time as chair of Type 1 Diabetes TrialNet, and began those interventions then. They're the ones seen toward the bottom, ATTG, and teplizumab, and abatacept. They're actually still ongoing in terms of follow-up, but were finished more recently since I stepped down as chairman. In general, we had some that showed transient preservation of beta cell function. That's measured here by looking at C-Peptide as an index of beta cell function, usually with a mixed meal tolerance test. And you can see that there might be transient effect and then a decline in parallel to the control or placebo group. This shows you one example of that with teplizumab, which is an anti-CD3 monoclonal antibody. And you can see that during the first 2 years of the study, looked like there was preservation at 6 months and then decline parallel to the placebo group. But here's the big but. If you separate out drug responders from non-responders, what one sees is that in the responders, there's actually sustained beta cell function for the whole 2 years, and the non-responders look identical to the placebo group. And I think that was an important observation that we really need to be dividing up individuals in terms of responders and non-responders, and perhaps selecting individuals for potential response as we select different treatments. And even here is a therapy, low-dose thymocyte globulin, which we found, that's the curve in blue on the top, had better preservation of beta cell function out to 2 years than placebo. And these two interventions, low-dose antithymocyte globulin and teplizumab, both of which are anti-T cell therapies, really seem to be the things that have worked the best to date. Here you can see the A1Cs in the group. The placebo is at the top in red, and the blue is ATG versus placebo. The green was another group that we included in the study, ATG plus GCSF, and you can see that it did have a better A1C there, but if I go back to the previous slide, it had only intermediate preservation of beta cell function. And in this study, we divided the p-value. It had to be less than 0.025 to be statistically significant. And the ATG, when we added the GCSF to it, did not achieve that. Now here's the most interesting study we've done. This is using teplizumab in people who had dysglycemia, that was stage 2 diabetes, where we intervened at that point to try to prevent the appearance of full-blown diabetes. And this study we reported last year in the New England Journal. And what you can see is that the hazard ratio when you use the drug is 0.41. Namely, we had a 59% reduction of the likelihood of progressing to type 1 diabetes, and the p-value was 0.06. And you can see that there were 9 placebo people who were diabetes 3 out of 32 in that group, and there were 25 out of 44 that were type 1 diabetes free in the teplizumab group. So diabetes was diagnosed in 43% versus 72%. The annualized rates were 15% versus 36% in the placebo group. And the median time to diabetes increased from 24 months to 48 months. And at the conclusion of the trial, which was events-driven, 9 of those in the placebo group and 25 in the teplizumab group did not have diabetes. And the longest follow-up without diabetes was 88 months in the teplizumab group. Most recently at the American Diabetes Association in June, we reported extended follow-up on this. The hazard ratio adding another year to the follow-up was still 0.45 or a 55% risk reduction. And you can see the curves continue to remain apart. And now the difference was 25 months versus 60 months. And 7 of those in the placebo group and 22 in the teplizumab group did not have diabetes. And now the longest follow-up was 99 months. This just shows you if we look at subgroups, that the best effect happened to be seen in people who were negative for zinc transporter antibodies, who were absent HLA-DR3, and who had present HLA-DR4, suggesting that we might be able to select potential responders by looking at those during future studies, although the currently studies that are being done for registration of the drug have not used those as exclusion or inclusion factors. Eric Topol, the editor of Medscape, tweeted out at the moment after it was presented at ADA in 2019 that this is the first drug to delay onset of autoimmune diabetes in high-risk individuals. He doesn't have quite as many Twitter followers as Donald Trump, but he is has the most Twitter followers in all of medicine. Okay, let's go on to newborn screening, though, because ideally what we want to do is identify people who are genetically at risk and follow them until they develop antibodies, and then intervene right at the time they develop antibodies, or potentially, if the intervention is safe, try to intervene in those who have high genetic risk. Now, in all of the TrialNet studies that I showed you, we were looking at first-degree relatives of people who have type 1 diabetes in terms of that's who we screened for. We screened collectively between our first studies and our second group of studies about 350,000 relatives, and we only get about 3% that are positive and that and less than that get enrolled in trials. This study, which looked at babies from birth, whether or not they had first-degree relatives, and looked at general population as well, you can see that the rate of development of multiple antibodies is the same in both groups, no statistical difference. So you could screen the entire population at birth for risk of type 1 diabetes if one wanted to. We already screened for many metabolic diseases. That's actually being done in a group that is being led by investigators in Germany, Ezio Bonifacio and Annette Ziegler, and they call theirs the Global Platform for the Prevention of Autoimmune Diabetes. And they look at genetic testing for the risk of the disease, and they have a merged genetic score. And the people with the highest genetic score have the greatest risk, more than 14.4. Their target is to screen 300,000 people in 3.5 years. So far, they've screened about 220,000 of those. And they have interventions which they're going to test even before they develop antibodies, just on the basis of the genetic score. What we've learned from prevention trials, though, either the ones we've done or looking ahead to this one, is that massive screening efforts are needed to identify potential subjects, that the yields are very small, and that population screening at birth may be the most desirable strategy to really be able to intervene early if we had a safe, predictable intervention. And that enrollment in prevention trials requires that the studies be subject-centric and relatively non-intrusive, is the other lesson. Lots more still needs to be done. And then we get to the studies that I showed you in the beginning, where people at the time of clinical onset of type 1 diabetes to preserve existing beta cell function. And I showed you that, there was often a transient improvement and then a decline in parallel to the placebo group. The question is, what do we need to do to achieve better results? And we hypothesize that the answer is aggressive combination strategy. We recognize that the immune system has 3 components, and what we would like to do is interfere with innate immunity or inflammation, with adaptive immunity, and we'd like to try to promote regulatory immunity. And also, we want to do something to preserve beta cell health. The beta cell is not an innocent bystander in this regard, but is really a contributor to because of various issues that it relates to make it more susceptible to damage. One proposal that we've put forward and that Camilla Ricordi and I have put in as to clinicaltrials.gov is to use the combination of an anti-inflammatory agent such as anti-TNF, an immunomodulation such as low-dose ATG that I showed you its effectiveness. We want to drive Tregs with the regulatory immunity with IL-2 and preserve beta cell health with GLP-1 receptor agonists. And we do have approval from the FDA to do this. It's on clinicaltrials.gov. It's been approved by the IRB, but getting the companies to give us the drugs, if you're going to use it together with somebody else's drug, has been a challenge. We're still trying to work through that because they say, well, they're going to have a side effect with their drug and you're going to blame my drug, and I use my drug to treat all sorts of rheumatoid arthritis or other things. Anyway, it makes it difficult to get this initiated. Hopefully we will. Our therapeutic goals also included, though, replacement or regeneration of beta cells. And beta cell replacement has actually been done for some time. Pancreas transplantation is done in the United States and elsewhere, and it usually accompanies kidney transplant so that you can put both in simultaneously. Islet cell transplantation that Camilla Ricordi and Rodolfo Alejandro have been leaders of in the world is usually done for recurrent severe hypoglycemia, resulting in emergency room visits and the like. And even if the islets don't have 100% function over time, just some function helps prevent the recurrent severe hypoglycemia and basically makes that problem go away. So these have been very effective, but ideally what we want to do is be able to do something for the entire population. And the issues in trying to deal with that are availability and a source of cells. It turns out there's only 1,200 pancreas donors that become available in the United States when we look at cadaver donors each year, a horribly small number. If we would switch from having to say organ donor on our driver's license to a system where the default is that you are an organ donor and you have to put not organ donor on your driver's license to opt out, we might increase the availability of organs for many diseases. But that's something which has just not been popular amongst our governing bodies. The other thing is we have to deal with the alloimmune response, namely rejection. And that becomes important. And it's also been demonstrated that you can have a recurrent autoimmune response even when you don't have evidence of an alloimmune response. And that was demonstrated in large part by George Burke and Alberto Pugliese here at UM. So one of the things to try to overcome the source of cells is using stem cells. And there's stem cell strategies. They can either be patient-specific, where you reprogram cells and transdifferentiate them, such as biopsying the liver, putting those cells in the laboratory, converting them to beta cells, and putting them back in. Or one can use allogenic cells. You can have a bank of embryonic stem cells, human embryonic stem cells, or induced pluripotent stem cells. And these are generic and can be used for multiple patients, centrally produced and more easily potentially commercialized. But then you have to deal with the immune problems. And for immune protection, you can have immunosuppressive drugs or immunomodulatory drugs, or you can have a physical barrier such as encapsulation, which has been extensively looked at here at DRI by a number of colleagues, and more recently led by Alicia Tomei and by Chris Fraker. And then you can also have the concept of gene editing for immune evasive or immune protection. So all of those are potentially possible. And so all four of these goals are potentially achievable as we look to the future. You have to have a lot of hope with that. This is the corner of Hope Junction. It requires a breakthrough and innovation. That's Breakthrough Boulevard and Innovation Avenue. That corner actually exists. It's in Ridgefield, Connecticut, in the U.S. headquarters of Boehringer Ingelheim. And when I was visiting there, I saw this corner and said, wow, that really does describe what we're trying to do, because you have to have hope that we're going to make it. But as I look ahead, I see that all these strategies will come to fruition and that we will get to a world where we can actually control and manage and defeat type 1 diabetes. And so I'm going to thank all of the people who sponsored my research efforts over the last many years, and thank you for your attention.
Jay, that was great. Thank you very much for the very clear presentation and exciting data that you presented to us. Is there anybody that would like to?
Yeah, I have a question, Roy. It's Michael.
Yeah.
So, Jay, I'm always curious as when you remove a significant arm of the adaptive immune system that it doesn't lead to other problems. I'm assuming that the anti-CD3 antibody gets rid of the T cell population. And that's one that we use.
Yeah, but it recovers. And
right.
so
sure,
what the course of the anti CD3 was only 14 days at the time of enrollment. The course of the low dose anti-thymocyte globulin was only 2 days, and so you do knock out the system temporarily, but as it recovers, it favors recovery of Tregs more than it does of T effectors. And so you end up with a better balance to be able to sustain the effects over time, even though you only intervene transiently in the beginning. And you do demonstrate that it has been demonstrated that you can generate de novo responses to new antigens, and that's been tested and shown, so that if you're exposed to a new infection, you will respond.
Thank you.
Okay, Dr. Rubin, please introduce our next speaker.
Our second speaker is Dr. Schartess Culpepper Pace. Dr. Culpepper Pace is a graduate of the University of South Florida Morsani School of Medicine, and she trained in internal medicine here at the University of Miami and Jackson Memorial Hospital before pursuing fellowship in rheumatology at Emory University. She's been practicing rheumatology here at the University of Miami since 2014. It's our distinct pleasure to have her speak to us today on extraglandular manifestations of Sjogren syndrome.
Good afternoon. Okay, is my screen coming through okay?
Yes, it's fine.
Okay, wonderful. All right, so my name is Sjögren Syndrome Pace, and I'm going to be going over a clinical vignette, and then we're going to go into a discussion in regards to some of the extraglandular manifestations of Sjogren syndrome. I have no medical disclosures or conflicts of interest to disclose. Okay, and this is just an overview. We're going to go over the clinical case. We'll do a review of Sjogren syndrome, and then we'll go into some of the extraglandular manifestations of Sjogren syndrome with special attention to neurological manifestations as well as some of the muscular manifestations of Sjogren syndrome. And then we'll kind of wrap up the case and then go into some questions. So DM is a 46-year-old Hispanic woman that I saw about a month and a half ago, secondary to weakness of the lower extremities. She had been experiencing this weakness for about 3 years, and she described it as difficulty going to stand from a seated position or going to get out of her car, things of that nature. She had even seen a neurosurgeon because her primary doctor had ordered some x-rays and had ordered an MRI study, and she saw the neurosurgeon about 8 months prior to coming in. She had the MRI, which noted some degenerative disc disease of the spine, but very mild. His exam was unremarkable. The patient was seen at UM, and so she was referred to physical therapy. She also carries a new diagnosis of autoimmune hepatitis, and this was diagnosed about 3 or 4 months before she had come to see me. The abnormalities with regards to her blood work had shown up probably about 5 months prior to that, and she had started treatment around the time of the diagnosis. Her biopsy with regards to the autoimmune hepatitis was consistent with cirrhosis and chronic hepatitis, and she, at the time of seeing me, was on prednisone for about 3 months and had started the azathioprine about 3 weeks prior to that. Past medical history is as mentioned. Surgical history is notable for an appendectomy as well as the liver biopsy. Family history is notable for 2 brothers with psoriasis. Patient is married. She works in medical billing and coding. No tobacco, alcohol, recreational drug use. Her immune systems is notable for improved fatigue. In January, the patient had been experiencing fatigue that had been progressive as well as some nausea. And hence she was diagnosed with the autoimmune hepatitis. But weight has been stable. She does note some episodic glandular swelling along the parotid glands for which she had had an ultrasound performed, which was reported as unremarkable. She endorses mild dryness of the eyes and intermittent dry mouth symptoms. No reported chest pain, no active nausea, vomiting, or GI changes. She's had some intermittent itchy rashes, and she also had a biopsy performed about a month and a half before coming in, and the biopsy was not consistent with vasculitis but non-specific dermatitis. The joints are without any synovitis, no swelling. She has good range of motion. She denies any changes in range of motion. She denies any numbness, tingling, paresthesias, no falls, no chronic headaches. Current medications are prednisone 7.5 milligrams daily, which had been tapered down over the last few months, and she's currently on azathioprine 50 milligrams a day. Her physical exam, she's a bit overweight, but she's in no distress. She's anictoric. Oral mucosa is with decreased salivary pooling, but no significant dental decay or obvious dental caries. There was no obvious swelling of the parotid or submandibular glands and no notable cervical adenopathy. Cardiovascular and pulmonary exam was unremarkable, and her abdomen was benign without any palpable hepatosplenomegaly per my exam. Her joints were without any synovitis, full range of motion noted. But what did stand out is hip flexors were 4 out of 5. Hips were without any pain with range of motion, with no paraspinal tenderness on examination, and dorsal and plantar flexion of the distal lower extremities were 5 out of 5. Her labs are remarkable for high titer ANA, and it's in a nuclear and speckled pattern. She has positive anti-Ro and LA antibodies greater than 8, with normal being less than 1. She has an elevated rheumatoid factor with normal being less than 14. Anti-chromatin is slightly elevated. Smooth muscle antibody is elevated as well. CRP is mildly elevated at 14. TSH was normal. Her CK that I have here was actually from 2 months ago, and this is on steroids, but it was still mildly elevated at 267. CBC was within normal limits, and the AST, ALT, alk-phos, they had all normalized by this time, and as well as the total Billy.
Yes, I'm right.
Okay. Now, before I go into the review of Sjögren syndrome, any questions about this patient's presentation to the rheumatology clinic? Okay. All right, so I'll continue. So Sjogren syndrome, it's a systemic heterogeneous autoimmune condition that is primarily noted for affecting the exocrine glands, but it is systemic. And so while patients will have, or diagnostic criteria include dysfunction of these glands, patients may have various symptoms and findings. The prevalence is 0.1 to about 4.8%. And this range with regards to prevalence just pretty much goes to the effect of diagnosing patients. We have various clinicians who are diagnosing our patients, from the ophthalmologist, the internist, the rheumatologist, and then we have using various diagnostic criteria as well for diagnosis. But with the prevalence being on the upwards of 4.8%, that makes it the second most common autoimmune inflammatory condition, just behind rheumatoid arthritis. So while this was previously thought to be very rare, it is not as rare as we had previously once thought. Sjögren syndrome can be either primary or secondary. Our talk will focus on primary Sjögren syndrome, but secondary Sjögren's is usually associated with another inflammatory condition such as rheumatoid arthritis, systemic lupus, or scleroderma, or another inflammatory condition. There is an overwhelming female predominance, 9-to-1. So Sjogren syndrome, our patients, they will present with various symptoms, but cardinal findings are around the sicca components with a significant dry mouth, dry eye symptoms, dryness of the skin, vaginal dryness. Patients may have dyspareunia. And on the pictures on the screen here, you have a patient with some mild angular chelosis. There is some fissuring of the tongue. You can see there are some dental issues going on as well. And then with regards to the ocular manifestations, patients may come complaining of increased tearing. They may endorse foreign body sensation or a gritty sensation to the eye, as well as, frequent infections involving the eyes. Systemic manifestations present just as well. Patients may have significant fatigue, and fatigue has been found in up to 70% of our patients with Sjogren syndrome. Lymphadenopathy, glandular enlargement, hematological manifestations with abnormal cytopenias, pulmonary manifestations such as NSIP, renal manifestations in the realm of interstitial nephritis, distal renal tubular acidosis, neurological manifestations, which I'll go over a little bit more, as well as musculoskeletal manifestations, usually a non-erosive arthritis. GI manifestations can be related to GI dysmotility, to autoimmune hepatitis, to primary biliary cholangitis. Cutaneous manifestations as well, urticaria, vasculitic changes, and then there are the lymphoproliferative conditions that are associated with Sjogren syndrome as well. And these patients tend to be at a higher risk for low-grade B-cell lymphomas, usually non-Hodgkin's lymphoma, as well as MALT lymphomas. So this picture here just shows us an example of the systemic nature of Sjogren's, with symptoms ranging from cognitive dysfunction to dyspareunia. Patients may present with chronic sinusitis, nosebleeds, gastroparesis, autoimmune hepatitis. So, and these findings have been associated with Sjogren syndrome in various cases. So the pathogenesis of Sjogren's is multifactorial, as with many of our connective tissue diseases, an interplay of a patient or a person who has a genetic predisposition, environmental factors, as well as hormonal factors. Hence, we have the overwhelming female predominance. I have the alleles here that have been most commonly found to be associated with Sjogren syndrome and autoantibody production here. On pathology involving glandular tissues, what we'll see is a periductal lymphocytic infiltrate involving the salivary and or lacrimal glands, composed of CD4 positive lymphocytes, Th17 cells, and this inflammatory cellular infiltrate leads to glandular dysfunction through cytokine release, fast-mediated cell death, interfering with glandular function, and also increasing risk of extraglandular ectopic cell formation. The cartoon here illustrates the patient who has a genetic predisposition, potential viral or exogenous exposure leading to a dysregulated epithelium, autoantigen release, stimulation of the plasmacytoid dendritic cells, and then we have this cytokine release, which begins this process with the humoral immune system, and you have the breakdown of self-tolerance, creating inflammation. Now, the serological profile in our patients with Sjogren syndrome varies, but most commonly we find patients that are going to be anti-Rho and anti-Li positive. These are autoantigens directed against ribonuclear protein complexes. And the anti-Rho and anti-Li antibodies, they're associated with an earlier disease onset in patients with Sjogren syndrome, also associated with recurrent or permanent parotid gland enlargement, and at times this can be asymmetric. And they're associated with these HLA alleles that I mentioned are listed earlier. You'll see ANA positivity in a large percentage of patients, on upwards of 85%. The ANA titer, or pattern rather, will be a speckled pattern most of the time, but we can also see homogeneous. And the ANA can be associated with hypergammaglobulinemia in these patients, which will increase our vigilance for some of those lymphoproliferative conditions. The rheumatoid factor is not uncommonly elevated in Sjögren's patients. It can be elevated on the upwards of 3/4 of our patients. And an elevated rheumatoid factor kind of makes you more alert to possible extraglandular manifestations related to Sjogren syndrome. At times, there is the question of whether or not the patient actually has rheumatoid arthritis versus Sjogren syndrome, but usually the patient with Sjogren syndrome is not going to be anti-CCP positive, and the joint pain is typically a non-erosive type of joint pain and doesn't lead to the severe joint damage that may be seen in rheumatoid arthritis. I'm not going to go into too much detail with regards to diagnosis because I go over the time frame here, but there are several criteria still being used and classification criteria still being used to diagnose our Sjogren's patients. Hence, you have some patients diagnosed, some patients not diagnosed. But the importance of the diagnostic criteria is to make sure we gather the inflammatory or the autoimmune component nature of this condition. I've listed the American European Consensus Group classification criteria here because this one is still very commonly used, and you have the subjective symptoms that the patient will describe, and then you have the objective findings that we see. Patients may have a minor salivary gland biopsy, objective findings on the ophthalmologic exam, and this just kind of makes sure that there's an inflammatory component to the diagnosis here. And to be positive or a high likelihood of having Sjogren's, you would need 4 out of the 6 to be positive, with at least 2 from the objective findings. I listed the ACR EULAR criteria, classification criteria here as well, because here we have a more simplified calculation here where if the score is greater than 4 and the patient meets inclusion criteria with symptoms, then the patient can be diagnosed as having Sjogren syndrome, and then we would go ahead and make sure that the patients are not with any of the exclusion criteria, which would include these IgG4 related diseases, graft versus host, sarcoid, and things like that, that wouldn't allow the patient to be diagnosed. So now we're going to go forward with regards to the neurological manifestations, and I want to mention that the neurological manifestations are very common in Sjogren's patients. This is in part to the referrals that we receive. Patients may have, neuropathy or nonspecific symptoms, and then they're found to have these abnormal serologies, and then they make it to the rheumatology clinic. But the prevalence of neurological manifestations in Sjogren syndrome is thought to be on upwards of 70% of patients. And in a study by Perzanska, it was found that up to 60% of patients with neurological symptoms would precede the diagnosis for about 2 years or so. You can have involvement of the peripheral nervous system with sensory polyneuropathies, sensory motor polyneuropathy, cranial neuropathies, autonomic nervous system dysfunction, as well as CNS involvement with cognitive disorders and MS-like lesions, demyelination, seen on imaging studies, as well as neuromyelitis optica and neuromyelitis spectrum disorders. The pathogenic mechanisms behind the neurological manifestations are not well understood. It is thought to be related to inflammation from this cytokine release and or possibly vasculitis, especially in our patients that may present with mononeuritis multiplex. T lymphocytes, dendritic cells via cytokine release leads to these inflammatory infiltrates that that causes dysfunction in the normal nerve function, as well as causing inflammation in the surrounding vessels that supply the nerves. The role in autoantibodies is not clear, but it has been found in patients with CNS involvement who have had LPs that the anti-Ro antibodies have been found in CSF in some of the patients with more severe disease. So patients that have neurological manifestations may have a distal axonal sensory polyneuropathy, and this will present with symmetric paresthesias and sensory disorders, primarily involving the distal lower extremities. It's usually an indolent course. The patients may mention loss of sensation involving the hands or the feet. They may have burning sensations as well. On exam, you may find diminished or absent deep tendon reflexes. And the nerve biopsy will be consistent with axonal degeneration with remyelination without necrotic vascular changes. So you don't really see the vasculitic changes in patients with distal axonal sensory polyneuropathy. Now, with the sensory motor polyneuropathy, these patients will also have weakness in addition to some of these sensory findings. And they have very intense symptoms at times involving the distal lower extremities, involving the extensors of the feet. The EMG on these patients would be consistent with axonal sensory and motor loss, with a predominance of the sensory fibers more so than the motor fibers. Now, treatment is typically symptomatic. So we're going to treat these patients with gabapentin, pregabalin, tricyclic antidepressants. And in patients with more severe manifestations or a really progressive course, we can consider IVIG in these patients. When it comes to the tricyclic antidepressants and gabapentin, we also have to balance whether or not the patients have sicca symptoms, because common side effects of both of these therapies includes worsening of the dryness of the mouth and possibly dry eyes as well. Now, mononeuritis multiplex is a much more severe complication related to neurological involvement of Sjögren syndrome. And patients have simultaneous or consecutive asymmetric nerve damage secondary to inflammation. The patients will have paresis, abnormal sensations, painful paresthesias, and dysesthesias. But because this is such an inflammatory process, you'll find constitutional symptoms, low-grade fevers. The patients will have marked elevation of the inflammatory markers, including the CRP, sed rate, and sometimes the ferritin levels as well. The goal is to do a biopsy after starting treatment, and you'll see necrosis of the vasa versum with T-cell infiltrates as well as macrophage inflammation involving the vessel wall. The patient has sensory and motor deficits on examination, and this is one of those conditions that we need to treat immediately. We want to start these patients on IV steroids and then start them on a disease-modifying or steroid-sparing agent, either cyclophosphamide, azathioprine, methotrexate, CellCept, and or rituximab, just depending on what other organ involvement may be involved and what suits the patient best. Small fiber neuropathy is not uncommon either. It's actually very common, but widely underdiagnosed. And this occurs secondary to damage to the A small myelinated fibers and the unmyelinated C fibers. And these are the pain fibers. And so patients will have dysesthesias, temperature and nociceptive stimuli abnormalities. They'll have painful burning sensations, allodynia. So these are the patients that we touch on exam, and there's a lot of pain there. On the EMG nerve conduction study, there will be no findings. This is non-lift dependent, so unlike some of the other conditions, these patients may have involvement of their face or different parts of the body with regards to these paresthesias. The skin biopsy is the diagnostic study of choice, and you'll see a reduction in the intraepidermal nerve fiber densities. And the treatment as well is symptomatic using gabapentin, tricyclic antidepressants, duloxetine. And there have been a few case studies where they've used IVIG in these patients as well with severe symptoms. Cranial neuropathies can occur with involvement of the trigeminal nerve. Patients have also had facial nerve palsies, as well as cochlear nerve involvement with hearing loss, vestibular symptoms. So in these patients that present with these abnormal findings, it is appropriate to consider an inflammatory or autoimmune condition such as Sjogren syndrome if there is no other culprit. Now, switching gears to muscle disease is not as common as we initially had thought, but the patients will present or can present with muscle pain, muscle weakness, or overt myositis. Inflammatory myopathies, the range here is 2.5 to 10%, but that is, based on patients that may present with muscle pain without objective findings of actual myositis. Biopsy-proven myositis is much less common, about 0.75%. But patients who do have bona fide inflammatory myositis associated with Sjögren, they tend to be anti-Ro positive. The pathognomonic mechanisms with these Ro antibodies with regards to myositis are, again, not clearly understood. But one of the other things that we must do in our patients with Sjogren's is we want to really evaluate these patients. Have they been on hydroxychloroquine? Although this is a medication that we typically use, there is the risk of myopathy related to the hydroxychloroquine. Does the patient have associated thyroid disease? Is the patient on a statin? So the initial workup for these patients that are complaining of myalgias, muscle weakness, maybe mild elevation of the muscle markers, we want to do a thorough review with regards to their history. And then from there, we do the workup, including EMG and or muscle biopsy as needed. And you can also consider MRI of the larger muscle group as well. One of the things we also want to do is we want to evaluate these patients for lymphoma, because smoldering lymphomas can also present with mild myositis as well. Now, in patients that do have biopsy-proven myositis, there have been studies that show the inflammatory myositis that is associated can be inclusion body myositis and or polymyositis. The difference is that from having inclusion body myositis alone or inclusion body myositis associated with Sjogren's, is these patients tend to have a more favorable response to treatment. Inclusion body myositis tends to be very resistant to treatment, and it really has a course where the disease is very refractory to standard therapies for myositis. But if there is the association with Sjogren syndrome, these patients do respond well and respond to IVIG as well as steroid-sparing agents, including steroids and methotrexate that can tend to be tapered over time. Similarly, for polymyositis associated with Sjogren syndrome, these patients tend to respond very well to steroids as well as DMARD therapy, and may not require the length of therapy of a patient that has myositis as a primary diagnosis. On presentation, patients with Sjogren syndrome, they tend to have slightly lower CK and muscle markers. The patients may present at any point throughout the course of having Sjogren syndrome. In some studies, the patients present anywhere from 2 to 14 years after having the diagnosis of Sjogren syndrome with muscle inflammation. Okay, so I'm going to stop there. We're going to go back to the case. So with patient DM, she had a full workup. The patient had a myositis panel that was completely negative. She had anti-Jo, PL7, PL12. The antibodies were all negative. As I mentioned, she had an MRI of the lumbar spine, which showed some very mild bulging of the disc at L2, L3 with some central canal stenosis, but nothing that would account for her to have objective weakness of the bilateral lower extremities. X-rays of the hip revealed mild degenerative changes, and as I mentioned, my exam was pretty unremarkable as it pertained to the hip joints. She did undergo an EMG nerve conduction study, which showed no large fibroneuropathy, but she did have findings of fibrillations and sharp spikes consistent with an irritable myopathy on the EMG nerve conduction study, which suggests that this patient has some component of muscle disease that was ongoing. Now, by the time she had this EMG nerve conduction study, she had already been on steroids for over 3 months that had been tapered. So that somewhat impacts the findings, but it is of interest to note that she has findings of this irritable myopathy. And then I did have the patient evaluated by her eye specialist, who diagnosed her with keratoconjunctivitis and started her on Restasis, which her insurance did not cover. So she was started on artificial tears. So sometimes when we're seeing these patients, we want to try to look for a unifying diagnosis. And this is a 46-year-old woman who been complaining of lower extremity weakness for a good 3 years or so without a real diagnosis as to why she continued with this weakness. And then she presented with autoimmune hepatitis, and she has these very high titer positive serologies and clinical findings and objective findings that are consistent with that of Sjogren syndrome. So the patient was diagnosed with Sjogren syndrome. She's on the azathioprine, and she's on tapering doses of steroids per hepatology for the autoimmune hepatitis. And she's doing somewhat better. She continues with a little bit of weakness, but we'll see where we go from there because she recently started the azathioprine. These are my references, and I think we can take questions.
Thank you, Schartess, for that interesting presentation. We are almost at the top of the hour. If there are any questions, please feel free to text us or email Dr. Culpepper-Pace. In the meantime, Dr. Deshpande has an announcement as to how we can register for CME and MOC.
Yes.
Dr. Deshpande.
Thank you, Dr. Weiss. And let me again apologize. I know we're trying to create as streamlined a process as possible. So what we've done for this session, if you go to the Gordon Center sign in through the link on the flyer, I know the live stream wasn't working for many of you. We're working on that. But if you go down to the part that says claim credit, that link should be active, and there's an activity code on there. Just make sure you write that down. Today's, I believe, is 111695, but just make sure you write that down or copy it. And then when you click on that link, it has you go into CME Tracker. And once you type in the code, it should very seamlessly go through the CME questions, asking you at MOC, doing the MOC as just a one-step process. And so that should be live now. So please try that. And we're going to have more meetings over the next week to ensure that this process becomes a very straightforward one for everybody. So thanks for your patience. If people have issues, feel free to reach out to me, but that link should be okay. Just make sure you take down that activity code number and log on with your CME tracker info. And then from there, everything should just be a one-step click process. So thanks a lot, and we'll continue to work on it.
Thank you, everybody. Have a safe day.